Hello, everybody. Welcome. I'm Dr. Soto, and today I'll be talking about Propel for everyday use, make it super practical. But since I'm a comprehensive dentist, the benefits of being able to do, pre-restorative dentistry, to be able to do, everything in a reasonable amount of time is a top priority to me. And you'd be surprised at how your conversations with your patients change when you talk to them and you tell them, that their alignment is going to be months instead of years. Today, I'm mostly focusing on the practical and the clinical stuff. I know you all can read, so if you want science and literature, we can provide you with all of that in writing as well. So I'm going to start sharing my presentation. Well, actually, I just wanted to say hi, make sure that you guys could see me before I started sharing my presentation. I'll be in and out from the presentation. I want to make sure that you guys understand and know that it's live, it's me, and I'm right here. So let's jump right to it. These are my disclosures. I am a KOL for DSD, for Invisalign, I'm an Align faculty, ACA KOL, and also, of course, a Propel KOL. And, these are some more of my disclosures. I'm not employed by any dental company and don't own stock, or which I should, and all these things that we have to say before a lecture. And of course, that these opinions are mine, and all of that, legal stuff. But let's just jump right to it. And like I said, today's lecture is not going to focus at all on the science. We're simply just going to focus on have a chat and how to implement the procedure in your everyday aligner patients and to maximize efficiency and of course the predictability. And we know the biology of how teeth move, right? We know osteoclast and osteoblast activity. And basically that it doesn't matter how much you push the tooth, if you're not respecting the rate of bone remodeling and those boundaries, you're not gonna go anywhere. And of course, lots of science that support this, but the basics are pretty simple. Teeth move at the rate that bone remodels. So if we increase the rate of bone remodeling instead of increasing the magnitude of force, then we'll get continuous predictable movement. And of course, that's really, really important. And yeah, basically what we just said. And then, MOPs do exactly that, and it does it by inflammation. I tell my patients all the time, I actually tell them, I want you to think about it as if, you're calling the troops for battle, you're faking a battle. And then when all the cells just show up and they come and they realize there's really no battle, they just need to help move teeth. And of course, cytokine levels increase, bone density decreases, and the rate of bone remodeling increases. And it's just really important to understand that, of course, the science is all there. But most importantly today, what we want to focus on is on some fun clinical cases. And I would like to start jumping right straight to a case so that you understand what's possible with, micro-osteoperforations. So this patient right here on the top, you can see, this case study on the top, we have, class 3 tendency, we have a very narrow arch, omega shaped. And then after 8 months of treatment versus what could possibly be a year and a half or more, we see, 5 to 7 day changes. And this patient took me, to this result in 8 months. In this particular case, I actually did 2 rounds of MOPs. And you can see, and like I said, I'm really going to focus today, and most of my focus today is going to be on how I achieve these things in a reasonable amount of time so that I can really focus on getting to that restorative result. I am an interdisciplinary comprehensive dentist, and most of my patients will come to me if they want a smile design. I want to make sure that I can do it in a really conservative way so that I can do tooth alignment and I can do all of the things that I need, but my goal is to get my patients to that smile that they've always wanted. So that's really, really, really important. And then, so in here in this case, we can see the MOPs, and then we can also see how we got to the restorative, and it's a pretty simple restorative case, 4 veneers from lateral to lateral. And the really cool thing is that you can see almost that progression of a really narrow triangular arch to month 7, nice and round. And on the lowers, you can see that canine that's totally boxed out, you know, getting better. And then you see some molar uprighting, so it's pretty cool. And that will always, you know, get you a happy patient for life, you know, that bond that you create, and those patients and those referrals. It's just really it's a very special thing to be able to give to your patients. So I think, you know, we all know the value of all this, but I think we should all focus on how do we actually do it? How can we do this? So basically, I'm going to go through some of the how-tos and some of that clinical stuff. And like I said, there's all kinds of literature supporting, you know, the use of micro-osteoperforations and why this works. But let's talk about how to make it happen and all the different devices. And we can start with, you know, the first device, and on the left is the accelerator. It's more like, think about it as a manual driver. It's autoclavable, it has tip options, and it's basically, you know, you go around like you're screwing something. And that was my very first case was done with that. And then you have the power tip driver on the right side, and that's, you know, it's like on steroids. Now you really get to be super efficient into what you can do it. And if you're anything like me, then you know that's really, really important. And so if you can see here, you can see that the from the accelerator, the manual, to the power tip driver. Of course, the power tip driver is my favorite. I haven't used the manual since probably the first time that I did my first MOPS case. It was a kind of a giveaway at a conference, and I got to try it, and I'll show you that case. But you know, this is really the gold standard, and you can use it, you know, for any malocclusion. You don't have to worry about the compliance of the patients because it's doctor controlled, and that's really my favorite part of this. Of course, it's faster, more predictable. And all kinds of really, really great things, and preventing extraction cases, or making cases that you would never think you could do them, to be able to do them because you have this, you know, in your toolkit. So it's very, very nice. And you really do get to that detailed stage, or that restorative stage, much quicker. And I get this question a lot. You know, why not a burr? Why not use a burr? And, you know, I mean, this picture is actually kind of scary. But I think the most important thing is, you know, I personally do what's absolutely best for my patients. If this is the only FDA approved tool to be able to do MOPs, then that's what I'm going to use it. I'm going to do on my patients what I like to be done on me. Some people use, you know, tissue punch. Sometimes some patients, you know, get a lot of trauma from this, and I love the atraumatic part of doing MOPs with Propel. And, you know, like I said, it's the first and only device cleared by the FDA. So some of the other questions are, you know, some of the other things that people do is tats, and you can get, I mean, all kinds of nightmare stories on that. And everyone always tells me, you know, Propel tips are costly. Why not just use a TAD? And the answer, you know, is truthfully just not designed for it. And if you were to fracture an instrument, you just turned a very simple procedure into a nightmare. So, you know, it's like everything. Things are designed for a specific reason, and the design matters. So the Propel tips, they won't dull and they won't fracture. I've never had any issues whatsoever from so many cases that I've done. I've never had any fractures or bends or anything like that. So when you use TADs, they're just not made for that, and the fracture risk then increases. The most important thing that you need to understand is that you need your tip latched to the driver so that you're able to tug back easily. And you're gonna see some videos that I'm gonna be showing you, but the beauty of these tips is that you have a lot of tactile control, and that's really important. So the length is also a little bit different. To get to that same diameter, you need to go a little bit deeper, when you're using TADs. So it's really, really important to note that the effect is probably, you know, you have to understand that, and I think it's really important that the effect is not only on that tooth or in that area that you're doing, but it's to adjacent teeth. So if there's a tough spot, you know, totally don't sweat it. You can skip it and then go to the adjacent area. And I do that all the time. And it's important to know that it's not just through cortical, that it's just through cortical bone. It's not just, you know, just, you don't have to go all the way in. So once you feel the bone, you can just pull, like, you know, like the tuck back, like, you know, the kind of like tactile sensation that you feel when you're doing endo. And there's just no need to go deeper. So especially if you have surgical experience, you really know how to feel that out. And like I said, sometimes if it's a difficult movement, you know, or a difficult area, and it's a difficult movement, you can go to adjacent areas as well. So let's go to where and how many. And like I said, it really depends on the case and it depends on what you're doing. If you have really difficult intrusions, I will usually do mostly on those areas where I'm doing the intrusions, and I'll actually leave the rest of the areas alone. And you just really need to be strategic about, you know, what the movement is. And sometimes if you're not quite sure, you're doing this with Invisalign, go to the tooth movement assessment, and if you see little blue dots, or if you see, of course, definitely just see a black dot, please do Propel. But if you see the little blue dots, that'll tell you that those movements are a little bit more challenging, and you definitely want to do a little bit more Propel around those. In terms of the depth, when people ask me the depth, it really, you know, I don't really use depth as a guideline, like as a guide. I really just use that feel that I get. And it really depends on so many things, on the biotype of the patient, and, you know, the area that you're going. But I think this is a pretty good rule. On the uppers, you'll go about 3 millimeters, and then on the lower posteriors, you go a little bit deeper. Especially remember that the bone quality on the lower is different than the bone quality of the top. And you'll also feel that when you're doing the MOPs, some areas you'll go in really easy, and some areas you really have to put a little bit of pressure until you get that in, and then you just stop. So these are really kind of like the 3 easy steps to get to that. Usually I'll do full bicuspid to bicuspid. So for those, and I think this is a question that comes very often. So I'm going to spend a little bit of time with this because, you know, a lot of people use a ton of anesthesia for this, and you really don't need to. I personally use only 2 cartwheels of septo and really spread it all out, you know, just tiny bit all around. And, you know, I will confess that when I started, I would use almost like 4 cartwheels of septo. And, you know, it's definitely not necessary. If you're only trying to numb the soft tissue, we know that that's easy. But this part is key to the process, because, you know, if you do the numbing as gentle as possible and as thorough as possible, you can really get a lot done. And, you know, truthfully, if getting patients numb is not your thing, then, you know, get a wand or get one of those devices that will help you with that. But I think this part is key, because most people, you know, don't want to numb the full mouth for and use so much anesthesia, and you really don't have to. Like I said, I routinely use only 2 cartwheels of septo. And truthfully, what I tell the patients is you should not feel any discomfort from the procedure that I'm about to do. But you'll feel is that, you know, once the numbing is going away, it's that annoying sensation of the numbness going away, and some of that soreness that happens after you get numb, but it's not going to be from my procedure. So I think that's really important to note. So another thing that's really important, I'm going to go back, is, you know, doing a chlorhexidine rinse before treatment. And then after, I don't do a chlorhexidine rinse, but as I'm going, and I'll show you a video, once I'm done with a quadrant, then I'll just put a little bit of gauze with chlorhexidine. And, you know, and I numb all of the area, and literally by the time I'm done numbing and I'm all the way to the lower right, I start on the upper right, go upper left, then lower left, and lower right. By the time I'm done, we're ready to go. So I infiltrate, that's my choice. And I know that if I'm gonna go a little bit more posterior, if there's something else going on, then I'll take a look at that. But usually my go-to is bicuspid to bicuspid. So of course there's a technique, depends on which appliance you're using. If you're using the replaceable tip on the manual, like I said, you hold tip at a 90-degree angle. It's almost like you're screwing, rotating clockwise while applying gentle pressure. And then you rotate counterclockwise once you feel that talk back to remove. And I have not used this one in such a long time. I almost forgot the feeling of that. But when you go to the power tip drivers, you can get a lot of that tactile sensation. And I'll tell you what my sequence is, and I'll tell you how I've maximized to make it, really fast and efficient in the practice. But this little power driver is a little workhorse in my practice. So basically, you on the bottom, you press and hold to turn the power on, and then you have to check a few things. The first thing you want to check is the angulation of the driver. And then you also want to confirm that you have the right torque. And I always go to 30, and I always go to high RPM. And then there's a forward and reverse. And the next video that I'm going to show you, it's a patient that I literally did a few days ago, probably, I think it was the end of last week. I was like, I told one of my assistants, can you just record this real quick, because I have a lecture next week. And you're gonna see, I mean, it's kind of hard to see. The angulation could have been better, and I had to turn off my lights on my loop so that the video wouldn't get wouldn't get washed out. But you're going to see, it has sound, and you're gonna hear me talk to my assistant, and I'll say forward, and then she clicks on the forward button, and she says forward. Now, when you have a rock star assistant and they really get the hang of it, this is a very fast procedure. I would say that we routinely do it in under 10 minutes. Of course, everything depends on the patient. Here's a video, and I'll probably, I'll try to talk, but I'll definitely explain on the next video as well. Okay? Okay. And forward. Forward. Reverse. Reverse. Forward. Reverse. 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 Forward. Forward. Reverse. Reverse. Forward. Forward. Reverse. Reverse. Forward. Forward. Reverse. Reverse. Forward. Forward. Reverse. Reverse. Forward. Now, I realized the video was a little bit jumpy. I could see that, but it actually is pretty smooth. The actual placement of it is pretty smooth. And I want you to pay attention on the next video. Now, that was just quickly showing how the process goes. You say forward, your assistant changes it, and then she sees that it changes, and the screen has a little thing that tells you if it's in reverse or forward. And even though the video is a little jumpy, on the next video, it's the same patient, but I personally changed the angulation of the driver to help me ergonomically. So because I've done it at this point so many times, I realized that I was better off, being more efficient by only changing the angulation of the driver once. So what I do, and I don't know if you could notice that on the video, but there's a few things going on. The patient always has a little bite block, and you don't need a fat bite block, just something to help them relax. I put the suction in there. Now, of course, I don't need it. I'm not using water, but the feeling of it and the sound of it, it kind of helps, basically even out the sound of the driver. Because what some patients told me at the beginning is they can't feel anything, but the sound of it, it's like more like this, a psychological, they don't like the sound of it, and it's not even loud at all. But what we do is we have this suction that helps, it drowns out the noise, and then We also always have music, always have music. There's another little trick too. Sometimes those little massagers that people use, like a hand massager to use in their neck, we have those as well. So then patients are getting stimulated with so many things. I mean, you can tell in this next video, you'll be able to see his face actually, and that's I usually start on the upper right, and I usually start on that angulation. And I'll start on the upper right, upper posterior right, and now move to the lower right posterior so that my angulation is the same. And that way, I don't have to change it, that many times. So I'm gonna just share the presentation again, and then okay. A little bit of vibration. Reverse. Forward. Forward. Okay, come closer, Jessica. Reverse. Reverse. So this is not this exact case, but this is one of my cases. 5 minutes. This was 5 minutes after I did the MOPs. I usually, like I said, I leave gauze with chlorhexidine just there a few minutes so that everything, cleans out, and, there's a little bit of bleeding, it stops. And, and I always tell my patients, I always tell my patients, I will be like, look, you're going to see tiny little dots. I don't want you to be touching anything with your hands. I don't want you to contaminate anything. And truthfully, I'll just tell them that so that they're not going to be like looking at things. And I always tell them, you're going to see tiny dots and they're going to be gone before you know it. And always, please take pictures of your MOPs. We save them in the patient chart in our software. So we have Dexis that all of the pictures go there. For insurance purposes, for every purpose, just in case, you always want to have the map of what you did. So this next, I'm a little upset at the fact that the videos are so jumpy, because I have this next patient. I wanted to share a video of her, and this particular case, she's this beautiful patient, and she's rocking her treatment, and we were just kind of like 3 months into a very complex treatment, and she was like in heaven, and she was so surprised and so excited about all the results. And I knew that this was one of those complex cases where I wanted to do a second application, and she came, and it's like, no problem, super happy-go-lucky, super excited about the progress of her treatment. And I was like, could you please, this was last week too, I was like, I am gonna do a presentation. Could you share with my colleagues what the procedure feels like? Because some people are always scared of, I have so many doctors that tell me patients are scared. They don't like the way that the procedure sounds. The consent is scary. I never get patients to say yes. And truthfully, I don't get patients to say no. And I can only think of one patient that I can remember that did not want to do the procedure. So I don't know if the video is going to come through. This patient is absolutely totally numb. She's completely numb. I just did MOPs on her. She put her aligners on, and then she's like, I'll do the testimonial. So hopefully it's something that you guys can see her. And she's quite beautiful. She's completely numb, so she looked a little funny, but she was very kind to be okay with just sharing this with you guys. You still look beautiful. So thank you so much for doing this. I just want to share with my colleagues about the treatment that we do with the stimulation and Propel. And we've done it. Now today is the second time we've ever done it. So I want to get a little bit of feedback. I want you to first tell me, the progress that we've had in the last few months, how you feel about that.
Unbelievable. I didn't expect so much progress so fast. I mean, I didn't realize how bad my smile was, honestly, until now. I'm looking back and looking at the screen. It's unbelievable in just 3 months how my whole side, not how a whole smile, completely different already. So I can't even wait to see what it's going to be like when it's done.
I know, and the thing is, you're so gorgeous. Like, to me, when I saw the canvas, it's like I get so excited.
I know.
But by the way, of course, you're really numb, and that's why you can't feel your lips.
I can't feel my face.
You can't feel your face, but it's a good thing because we just did simulation today again, because I really want to get going, right? We both want to like just go for it.
Absolutely.
So 3 months, huge progress. Now we did it again. And would you mind sharing, even with, you know, other patients, what does the procedure feel like?
It is different. It's uncomfortable a little bit because you do have something else in your mouth you're not used to. So at the beginning, I was like, this is going to be a little hard. But honestly, after the third tray, I can say that it's just standard. I mean, I'm popping them in, popping them out. No big
Part
deal.
of life.
Yeah, exactly. So I feel more comfortable with them in than out at this point.
Yeah.
So it's a breeze.
Awesome.
And seeing the difference.
Right, that's the motivation, right?
Exactly.
So and I'll probably be doing this again next time I see you, so you're not numb, so you can talk about the actual experience.
That's
but
right.
Because I am presenting next week, I wanted to, and I saw you, and I love, you've made my day to see your progress. I wanted to share with the world. So how about the actual stimulation procedure? How does that feel? Was like is, you know, it's what makes us go so fast too. So tell me about
I feel
that.
nothing during the simulation. The only uncomfortable part is being numb afterwards, but I'm going home. I don't care.
Okay, awesome.
So you guys can see that, you know, even, I mean, she had just had it done, and she was so happy, and so it wasn't a big deal. And like she said, I always tell my patients the worst part is the feeling of numbness and then it going away. And I always warn them, like, you're about to feel really weird, and it doesn't matter how much I tell you that it's gonna feel really weird, it's gonna feel really weird. And they'll always say, and I was like, I told you so. But it's more the numbness and the fact that you're preemptively explaining to them what that feeling is going to be like. I think that's really big. So let's talk about after treatment, you know, what happens. So basically, you know, you know, the sensitivity itself, it's really not much. Some patients may experience some tenderness around the treatment site, and that's really rare. And I always tell them no anti-inflammatories. You cannot at all, you know, have any Advil, ibuprofen, Aleve, none of that stuff. And of course, you know, I always actually give them Tylenol just in case, you know, because I want the whole experience to be really good. So let me just share with you guys what my protocol is. I always do MOPs on the delivery date for, I would say, almost always. So unless there's like a schedule situation or something like that. And when the patients come, I place their attachments. You know, my assistants play the attachments. You know, we'll do the rinse, and then I'll do the anesthesia. And like I said, 2 cartridges of Soto is plenty. Then I go ahead and do my MOPs. And then if I need to do any IPR, I actually do it right after I do the MOPs. And it's perfect because IPR used to be kind of annoying, but the patients are already numb because you were going to do MOPs. So I think this is really important because it's all about the experience. To me, it will always be about the experience. So I try to plan my cases with whenever I can do IPR to be done at the first stage. So if there's a IPR needed and there's a lot of crowding, of course you can't do it. But if I can plan it on the adjacent side and it won't change my plan that much, or I can distribute it between, you know, adjacent 2 sides, then, and I can do it on that first stage, then it's gonna make the whole experience better, and it's gonna save also on chair time. I do 5 or 7 day changes depending on the type of case. You can also do 3-day changes, which I've done as well, especially when you use high frequency devices like vPro 5. And like I said, make sure that when you're there, have music on, the low speed suction to drown out the noise of the driver. And they might not be feeling pain, but the sound is not comfortable. So that's always helped me a lot. Now, the next video I'm about to show is basically I'm showing the driver and almost like my little sequence. And I just told you that if you really think about the way that you're sitting in the chair and when you're working on the positions, I am basically, I'm not at the 12 o'clock position at the beginning because I'm working on the upper right. And the key here is to make sure that the angulation works so that the front of the motor and the little screen of the motor is actually facing your assistant, because she's the one, you're checking the clinical side, you're not really seeing that little monitor. So it's really important that your assistant has direct visibility to that little monitor, because she's going to change it and then she's going to see that it went in reverse, and then she's going to confirm and she's going to say reverse. So in this little video, I'm showing a little bit of my sequence, and then I'll talk to you guys a little bit more about that. So let's show it real quick. The driver, the tip, will be facing that interface. You could change it to your convenience to whatever other angle you want, but I always start with the same as facing the front of the motor, because the way that I'm going to start, I want my assistant to be able to see that little monitor at all times, because it's her job to go forward, reverse when I say it, and that way she can see the screen. So let's say I'm starting with the patient, and I'm starting on the upper right, and the patient, and I'm about the 11 o'clock position, 10, 11 o'clock, and I'll go boom, 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 maybe multiple sites, and then my assistant can see the monitor. At the same time, I'll go on the same, I'll go down, boom, 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 and it's at this point that I'll come to the 12 o'clock position of the patient. I will switch the driver to this angulation. So now it's facing towards the left if you compare it to the front of the screen. And then it's pretty simple. I'm at the 12 o'clock position, and at all times my assistant can still see my monitor. So then I go all the way, boom, 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 boom. Usually I'll do multiple osteotomies, boom, 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 boom. And then I'll come here. I never changed my driver. Boom, boom, boom. The monitor is always visible to my assistant until the end. And that's all right. So hopefully that was a little bit helpful, because at the beginning I was all over the place. I would do all of the top first, and I would be changing my driver, and then I would be changing the bite block. And on this sequence that I just showed you, I don't change the bite block. I don't change anything. If it's a really small mouth and I need to change the bite block when I'm going on the left, then I just do it once and that's it. So let's talk about patient communication, because it's just really, really, really important. And I really want to make sure that I really go in depth in this, because I think this is the most important thing. And basically what you need to be thinking about is always have in mind that using those scary words of what we're actually doing, or making a really big deal like we're drilling into bone or things like that, it just it sounds awful. So basically what I usually offer it is like, with like, I just make it sound really easy. I make it sound really simple, and like I said, I get almost 100% patient acceptance. So I usually offer it as an option too, but I highly recommend it, and I really hype it up. So I basically will tell patients, we do a procedure that can help you increase the predictability of your treatment and decrease the time in half. Would you be interested in something like that? Another thing that we do is talk about, acceleration versus stimulation. It's quite different when it sounds like acceleration. It's like I'm making things go fast. When we're talking about stimulation, it has a different meaning to patients, or at least we've noticed that. Make sure that you train your team. Your team is huge. It's huge. Like, your team is always huge, but your team is really huge on this, because they're the ones that are going to get like, oh, I'm scared. And then they're going to be like, no, it's really simple. It's only 10 minutes. It's just the numbing or things like that. So make sure that you have that communication, the words, and that's that you really have that in mind when we're, talking about these things. So the other thing that you need to take into consideration is that YouTube is not your friend. When patients Google and they go to YouTube and see what it is, truthfully, if patients saw what it was directly, it is kind of scary. So and that consent as well. I mean, we usually I'll be in the room, or we'll give it in the operatory, so we're ready to answer all the questions. And make sure that you communicate throughout the procedure. You know, I always tell them before, just like anything else we do, but in this particular one, I will tell them, you know, let me test it out. I'm gonna test it out on one side. Let me know what you feel. You're gonna feel a little bit of vibration and pressure, nothing else. That's all you should feel. And then once you do one or two, they're like, I don't feel anything. So and then once they experience that, then you're like, you know, then that's really what you're gonna be feeling in the next 10 minutes. And truthfully, the idea of what it is so much worse than it is. But you have to believe it in yourself, like everything we do. So let's just jump to a few cases. I have some cases that I did a while ago, and I have some newer cases too, so I'm gonna try to go through all of them. So this particular case is a super simple case, and it's one of those cases that I have in, you know, I have a show book of, like, you know, showcasing some of my cases, and this one is just happened to be on the first page. And it's just really, really important to have a really simple case as a slam dunk to show people what's possible. And this particular case took me 3 months. And the reason it took 3 months, it should have taken much less than that. It took 3 months because she didn't want to start it right away. And then she changed her mind, like, you know, 2 to 3 weeks into the process. And then, but the total case still took 3 months. So, you know, when you talk to patients and you tell them, you know, the thought of someone thinking they're going to be in treatment for 8 months or a year, anything will deter patients from getting alignment done. So now you're talking about 3 months, 4 months, 6 months. It's a big deal. And that always, you know, because of course I'm a restorative dentist, I will always look at that chip, look at what's happening. It's all because of the bite. This is a really young patient, and this is what they did. And these are the kinds of patients that if you nail the communication and you show them similar cases, you will do so many more of those. And, you know, a lot of people are like, okay, this is beneficial for my patients, fine, but, you know, what's in it for me? And I think it's really important to understand that, you know, the benefits for us as doctors are really obvious to me as well. You know, of course you have less chair time, and of course you have more predictability, and of course you have a higher compliance, and all of those things are enough, but then there's more. We will usually get so many more referrals. I have so many patients that tell me that, you know, they're sending their friend to me because the other doctor, well, it always starts with the other doctor didn't have a scanner, or the other doctor didn't show the patient, you know, my friend, what it's supposed to look like once we're done. So those referrals are huge, and now we have that added bonus of, like, you know, and then you do something that really, really makes it go so much smoother and much more predictable. So that's a huge benefit. So more referrals, of course, avoid longer treatment and patient burnout. We all know that happens. We also have that additional fee. So you either charge the patient, or, you know, it's an insurance covered fee as well. And it really increases the amount of, the amount of complex cases that you do. Maybe there's a really difficult case that you would have never done before. So I'm going to show you a case that my very first Propel case. And, you know, like I told you before, this was when the manual driver and a disposable sample that I was giving. And I am not saying that this is a perfect case by any means. This is a patient that, you know, she wanted me to help her, and was totally open to trying things out. And you can see that both canines here were crazy. But also notice, you know, how the upper right canine is in crossbite. And, you know, as everything, the key to everything is communication. We both knew that upper left canine was a big challenge, regardless of the modality of treatment, regardless of however this ortho was going to be done, it was going to be a challenge. And the patient was happy to give it a try. Now, I'm briefly going to talk about high frequency vibration devices because they're also helpful and they have similar benefits. You know, they increase the rate of the tooth movement, and they improve bone quality during the retention stage. It can also help sometimes when relapse retention. You know, if there's a little bit of shift and the patients are still on retainers, you can do high frequency devices, and that can help seat again and get back to it. I've actually done that with Propel. Sometimes I've had those cases, and then we do Propel, they go back right away. And then we have so many other benefits, but at the end of the day, of course, the reduced refinement and reduced treatment time will always trump anything. And this is what it looks like. And some patients even say it's really soothing. It's a really soothing, feeling. And it has a wireless charging station, little travel case. It has a little app, so it's another added benefit. A lot of people that use this also do it with Propel, and then you're changing aligners every 3 days. And I'm gonna jump to now for the rest of the lecture for some cases, and like the title of my lecture is, how do you get to do more of these interdisciplinary cases? And a lot of times it's gonna be, time. A lot of times is the patients will be like, I want this now. I don't have time. And I know that the quality of treatment that I can do with the time being now instead of just in a few months where I can align things a little bit. And I don't have to align them to absolute perfection because I know I'm doing restorative. But if I get to convince the patients to give me 3 months, to give me 4 months, then I know it's going to make a big difference in their decision making, and it's going to be a huge difference in the final result that I get to give. So I always think about this as a little launch. I'm launching the case so that I get to do what I really love to do in a more predictable way, in a more conservative way. So pre-restorative alignment that's really conservative is a big goal for me. So let's jump to some of these. This particular case, anytime I share it, I always have to give some of that attention to those laterals because those laterals are pretty crazy. And we all know, if we've been doing this for a little while, we all know that laterals are just very difficult and very stubborn. And in this particular picture, you can see that after 8 months, we have some pretty nice alignment in here. And of course, those laterals are the ones that really jump at you. The lower anterior area, you can see some really amazing movement as well, but those canines will still be, the most impressive ones. I believe when I see the tooth movement table, they were like, the movement was like something like 60 degrees or something crazy like that. And it's not only about speed, but the predictability too. It's not about moving that lateral faster. It's just about being able to actually move it. And then, you can see the different arches, and you can see, where we made it in those arches. And now this is an arch that I can actually restore. This is a bite that I can actually restore. So we go from that top picture to that bottom picture. And of course, it was a deep bite with severely rotated laterals and moderate to severe crowding. And, I did 2 MOP applications on this one. I did Invisalign first, then I did restorative and whitening. This is another cool case. And the cool thing about this case, and it's a kind of a complex case, but you can see in this little video how crazy that bite is. It's a narrow arch and it's a really deep bite. And for me to be able to do any restorative on this patient, he would have destroyed everything. He is destroying his own teeth. Why would he not destroy what I would put on him? And here on the 2 different scans on the top, you can see the before, and on the bottom, you can see the after. And the most important thing that you can see here is how on the after, on the lower scans, you can see how that occlusogram, or that diagram of the heat map of the occlusion, you can see how the anterior area it's not hitting like crazy anymore. You can see how the bite is a little bit more balanced. And you can see that we improved the occlusal patterns, we widened the arch. And this is, to me, one of the most important things that I get to do with Propel that I cannot do without any of that. And because I do a lot of pre-restorative alignment, in this particular case, I needed to level these teeth to be able to do any predictable restorations. So in just 5 months, this was 5 months, I was able to level the lower anteriors. And if you've done intrusion and deep bites, those are really, really difficult ones. And it allows me to be able to give those beautiful restorations to him. Very happy patient. This next case that I'm going to show you is not an interdisciplinary comprehensive case, but it's a very recent case, and I was really, really excited about it because it's what we do is so much more than all of that clinical stuff. And when you see this girl on the left, 14-year-old, gorgeous, that's really not the smile that a 14-year-old teenager, going through so much and then also having to worry about their smile. And then, and here you can really see some of the changes. You can see the initial on the picture on the top right, and then you can see how after 7 months, we were able to get all of that crazy alignment and those canines and that deep bite and, the leveling that we did on the bottom. And you can see on the left, the lower crowding, the lower anterior crowding completely resolved. This was in one set of aligners, one plan of aligners, and just one MOP session. So it's just really, truly amazing. And then this next case, and I added these cases kind of last minute because I really wanted to show and share some of the stuff that's been going on lately. This case, I'm actually working on literally as we speak. This case is in the lab, but the picture on the left is, this is before we start any treatment, and I do a lot of, digital smile design and mock-ups and test drives. And this picture on the right is a test drive, and the picture on the left is her, with her teeth, and she had dark teeth and she had, misaligned teeth, and she really wanted to have a Hollywood smile. And when you look at what's going on with her bite, and this scan is before any treatment, when you look at what's going on here and when you're seeing that bite, it's almost edge to edge, you see those laterals really flared out, you see those centrals really coming in. It's not that I can't do veneers in this smile or in this bite, it's just not necessary to have to restore in these conditions. You can see the lower crowding as well. And then this is after alignment. Once again, do I need to get to perfection? Absolutely not. I just need to get everything in a pre-restorative alignment stage so that I can get to, deliver my promise and do everything that the patient came in for in a more conservative and, non-invasive way. Some conclusions here. Please make sure that you choose your words wisely when communicating the procedure. Just practice and get confident with the feeling of it so that you can transfer that confidence to the patient. It's pretty easy. I mean, you just have to know your anatomy, understand the difference between how it feels between the maxilla and the mandible. Some cases like the tip of the driver, it'll just go in. And some cases like the patients, like their bone is really strong and it's gonna take a little while to break through that cortical plate. Make sure that you're aware of the contraindications. Head and neck radiation, biphosphonus, systemically compromised patients, of course, don't. And don't let the patients walk out if there's any bleeding. It gets on the trays and it just is not a good, it's not a good view of them if they're going to the bathroom and they just have like, a little drop goes like all around the aligners and then it's over. That fear really becomes real. And then, like I said, team training is huge. If your assistants know your steps, you're going to finish this in less than 10 minutes and make sure that you follow a really predictable sequence every time, no matter what. Most of my patients will actually recommend it to their friends or make fun of them because their doctor doesn't do it, and that's totally true. Make sure that you play some music and have fun. So I hope that was helpful. You can always message me on Instagram. You can, anything that I can do to help you or answer any questions, I'd be happy to. And yeah, that's it. Now, hopefully we have some questions. So we're gonna move to the Q&A, and let me just get to that real quick.
Let's see, how much do you charge per procedure?
So if patients don't have any coverage, so my patient population is very diverse. I'll have mostly private patients, but I do most of my patients that I do alignment on, they do have some ortho coverage. I would say almost maybe a third or half. I don't know. But if there's no insurance coverage, my fee is $500. If there's insurance coverage, then whatever, you know, the fee from the insurance is, and it usually will come out to be a lot more than $500. And when insurance covers it, patients has a copay, but it's usually less than the $500 for the patients, and then you'll get paid more. So we've gotten you know, some really nice reimbursement from insurance, from PPO insurances.
Okay, thank you. Another question. Do you rely on a panoramic or use a CBCT to determine MOP sites?
I don't use a CBCT. I mean, I have a CBCT in the office. I use it for implants, but I don't use a CBCT for MOPs. I mean, we know the anatomy is pretty simple. So if you really think about it, if you're going in the uppers, bicuspid to bicuspid, there's nothing there that you're going to mess up. And then on the lowers, sure, you have the mental foramen and you know pretty much where it's at, and then you can rely on the PAs, and you can even look at the panels, but the panel has a lot of distortion. So if anything, if you really want to be 100% sure, just check on the PAs. At this point, what I usually do, and depending on the movement of teeth that I'm doing, if I have a lot of movement on the lower premolars, yeah, I'm definitely mapping and I'm looking at the x-rays. But for the most part, when I'm doing the regular movements, you're usually going much higher up than the anatomy of where the mental foramen is. Of course, always confirm with the x-rays. But no, I don't use a CBCT for that.
Okay, how often do you repeat the MOPs in the same patient?
Those cases that I showed you, because they were a little bit more complex, probably 2 times was the maximum that I did. I don't think I've ever done more than twice.
Thank you. Okay, and one more question will do. Can you sterilize and reuse for a second time in the same patient?
No, you can't. No, you can't. So you'd have to use a brand new tip as well, because they're single use.
Okay, thank you. We'll wrap it up there for the questions.
Wonderful. Well, thank you again, guys. Thank you, everybody. Have a great night, and thanks for attending and taking some of your time to, to watch and learn. So just keep on rocking it. Bye.